We're a little behind the lab also. I think we're supposed to have our lab, the second lab test Thursday, but we've moved that to next week. And I don't really like being pressured. I don't really care, actually, being pressured. I'm not taking the test. But I don't like feeling like I'm putting pressure on you for timing. So I'm going to go through it, but I do like the idea of having a day where we can just talk about it and do review. We can do that Wednesday or Thursday night if you want, or if you guys want to move the exam until after the weekend, that's okay too. You don't have to decide right now. You can talk about it, and we can text each other back and forth over the next couple of days if you want to think about that. Talk to one another about it. So here's what we have left. This exam is basically the muscles and the innervations from head to toe. And so there's a lot of detail on this test. This also is the content of your lab exam, so it's not like you're learning new things. They both have the same content. At this point, we have made our way all the way to the lumbar plexus. So I made a point, I'm hoping all of you watched the lecture online. Some gentle nodding helps me know that you did that. And so we have the lumbar and sacral plexus left. This is not nearly as bad as the brachial plexus. That's good news. So we'll just work our way anatomically around at this point. We introduced this very briefly on the slide set that was online, but I want to go through it with you again, and I wanted to say a couple things multiple times. Just as you think about dissections later in your life, that'll be helpful for you. So, as we've been walking through the anatomy of the muscles and their attachments and how they're innervated, we've come upon the cervical plexus, the brachial plexus already, and today lumbar and hopefully into the sacral plexus. And I like for students to feel this sense of confidence. If you stand over a cadaver and you're going to do a dissection and you want to find these nerves, what would you do to find them? How would you go about cutting to get this started? And so I mentioned this right toward the end of that online lecture. If I wanted to find the major branches of the cervical plexus, I would dig deep to the sternocleidomastoid. That's a great anatomical landmark for digging in to the cervical plexus. Now, your lab manual does not require you to learn all of those nerves in the cervical plexus. It does, however, ask you to learn the branches of the brachial plexus. So your lab manual has the musculocutaneous, the ulnar, the median, these major nerves that it wants you to find. So, similar question then, how would you go about finding the brachial plexus? And this is not like the standard universal way to do this. I'm just giving you a tip as to how I think would be good to do. Find the bicep, brachii. So do the dissection of the bicep and find the nerve. It's clearly visible in the cat and humans. When you open up the anterior portion of the brachium and find the bicep, you will see the nerve there. And you will have no doubt then, there's no sort of, is this really the nerve? That's it. That's the musculocutaneous. Then you can walk your way back up the musculocutaneous to the lateral cord. And you guys know the lateral cord feeds the musculocutaneous and the median. But the median nerve also gets information from the medial cord. And so by tracking the musculocutaneous backwards, you can find the cords and the other nerves. And you can walk your way up and down from that point and learn all the brachial plexus nerves. That's what I recommend that you do in the cat, actually. And then this one, the lumbar plexus, I mentioned right at the end. The mistake students make in the cat, whenever they start looking for these nerves, specifically the femoral and the obturator, the two big nerves of the lumbar plexus, is they don't dig deep enough. You guys have been careful in dissecting your muscles. And so the pectineus, for example, and the adductor longus here in the groin area, the gracilis, you've been careful to dissect those muscles, to find them. And you haven't opened up the abdominal pelvic body cavity. Now, some of you have cats that are already open because they cut a big hole whenever they were trying to inject the hepatic portal veins. So you've got guts showing already. So I want to say this out loud to you so that when you get in the lab on Thursday, you're doing this. Don't be scared to go deep. You're going to actually have to go into the pelvic body cavity to find the nerves of the lumbar plexus. They are deep to the psoas major muscle. So today I'm going to teach you the psoas major and the iliacus. We'll learn their attachments and their innervations, and this will help you see just how deep. When I say the iliacus, I'm talking about a muscle that is fused in the iliac fossa. It's all the way down into the iliac fossa. You've got to get that deep in order to get to the nerves. So you're going to have to go into the pelvic body cavity to find where the femoral and the obturator branch. In fact, you will see some of the key blood vessels at this point in your dissection that will come up in the weeks to come. All right, so as I said, the major nerves are the femoral and the obturator. And I made a big deal about this one also, the inguinal ligament. This is going to be, I'm going to teach you this today. The inguinal ligament is the superior margin of the femoral triangle. Two ways today in the medical community, two general ways today to look around in coronary blood vessels if a person's got a heart problem. The easy way, the easiest way, is to go into the radial artery. You can feel the pulse and you can stick it. With just a little bit of practice, you can learn how to get something into the radial artery. But if you want to send things through, as it were, coils, stents that you're going to put in the coronary arteries, you need a bigger blood vessel. And for years, the radial was not the access at all. For years, cardiovascular surgeons would enter through the femoral artery. And so that one is located just inferior to the inguinal ligament. It's a really important palpation spot, an anatomical landmark location, this inguinal ligament that extends from the anterior superior iliac spine over to the pubic tubercle. And so there's a little gap there, right on the other side of that ligament. The femoral artery is in that gap. And today you're going to learn that the femoral nerve is in that gap, and the femoral vein is in that gap. We'll talk a little bit about their sheaths and coverings and the borders of them. So this is going to be a really important spot, the inguinal ligament. The obturator, then, the other of these, passes through the obturator foramen. And you guys know this from the skeleton. Where is the obturator foramen? On the coxa bone. Is it an anterior or posterior hole? It's a posterior hole, right. It's not really a hole in our bodies. It's covered by a ligamentous sheet. But the nerve, then, is named for this hole passing through there. And is it more medial or more lateral? It's more medial, yeah. So this nerve here is going to feed all of the adductor muscles, all these muscles on the medial aspect of the leg. Now, let's talk a little bit of detail here, and then we'll start our dissection. I'm going to go to the psoas muscle shortly. It's coming right here, psoas major. All right, but a couple other big picture things before we get there. We'll return to this slide over and over and over and over again. This is the general description slide of the lumbar plexus. So the two big nerves, as we said, are the femoral obturator, and they go L2 to L4. So just have a look at it. So there's the obturator nerve right there, and you can see that it's picking up information from L4, from L3, and from L2. Same thing for the femoral nerve. You see the femoral nerve picking up 4, and 3, and 2. And so the two major nerves of the lumbar plexus both come out of L2, L3, and L4 from the spinal cord. And that, remember, is what we mean when we say plexus. Many different spinal cord segments feeding an individual nerve. All right, now, The femoral, I'll say it and I'll show you a picture. The femoral is responsible for the sensory information on the anterior medial thigh, medial leg and foot, hip and knee. So the femoral is a huge nerve covering the skin, the sensory perception, essentially all the way down the front of your leg. Now, notice that it's described as medial here for the leg and foot. The word leg here actually refers to the portion of your leg distal to the knee. And so I'll show you a picture of that in just a moment. The motor stuff is the stuff we're going to really emphasize, and that's the innervation of the muscles. So the sartorius, a border muscle for the femoral triangle, and the four muscles of the quadricep, the pectineus, and the iliacus, misspelled there, sorry. We'll look at each of these in their turn. And then the obturator, as I just said, is on the medial thigh, and then its motor stuff is mostly adductors, the adductor magnus, the adductor longus, the adductor brevis. Annette sent me a text asking me over the weekend about the adductor femoris, a muscle in the cat. There is no adductor femoris in the human. We call this one the adductor magnus. So it's the same muscle. Makes it difficult when they don't name them the same things. I point them out to try to alleviate that confusion. And then the gracilis, of course, that little thin strap muscle on the medial side of your leg, from the pubic bone all the way down to the medial proximal tibia. Adductors, these are all adductors. All right. Now, we mentioned these two, the iliohypogastric and ilioinguinal in the last set. Those are the iliohypogastric and ilioinguinal, those are the top nerves. The top ones in the lumbar plexus. They are responsible, remember, for the abdominal area, along with what other nerves? The external oblique, the internal oblique, the transverse abdominis. Yes, are they innervated by a plexus of the thoracic? These are the intercostal nerves that come off of the thoracic divisions of the core, right? So we talked about that. All right, now here's a picture I like. It sort of does it good justice. It shades the areas that we just talked about. So you can see obturator here, medial thigh. You can see the femoral picking up anterior and lateral thigh, and then medial leg all the way down to the foot on the anterior side and the dorsal side. Now this is a little bit problematic here. It's not horrible, but when we get to the sacral plexus, we're going to have to distinguish between the muscles that dorsiflex and plantar flex. And we are not going to talk about the femoral and the obturator. That's going to be tibial. The tibial and fibular nerves that do that. So anyway, these pictures give you a good impression of the dermatomes. This is the tibial nerve here splitting into tibial and fibular. So you think of the posterior aspect of the thigh and leg as being innervated by the sciatic nerve. Now this is the dermatome that says that. You can see L1 to L4 here. And so in just a moment, we're going to start talking about the vastus lateralis and the vastus medialis and the rectus femoris and the vastus intermedius, and these big muscles on the anterior portion of the leg. And I'm going to say again, the femoral nerve gets L2, L3, and L4. So if you learn the motor innervation of the plexus to the muscles, look what else you just learned. You learned the sensory story as well at the same time. So the plexus information gets you both. If you just learned the motor, you learned most of the sensory at the same time. All right, so let's dig in. If we're going to find the lumbar plexus, it's down here, and so as major muscle, which has its attachments to the bodies and transverse processes of the lumbar bones and goes to the lesser trochanter. Now, stop for just a moment. Let's think about orientation here. The muscles that are deep in the thigh, this one and its cousin, both considered this iliopsoas muscle group, both of them are going to attach to the lesser trochanter. Now on the arm, we have a greater tubercle and a lesser tubercle. On the leg, we have a greater trochanter and a lesser trochanter. And it is fair to think about the greater trochanter of the leg as being a kind of mirror image, if you will, the same kind of projection as the greater tubercle of the arm. Both of them are lateral knots on the bones that stick out laterally. They're out here. The greater trochanter's out here. The greater tubercle's out here in the lateral aspect. On the arm, however, the lesser tubercle is on the anterior side. That's where the subscapularis of the rotator cuff goes. It's the only one supporting there on the front. So it is an anterior piece. On the leg, the lesser trochanter is actually on the back side of the femur. And so here we are deep. That's another way to illustrate it. We are very deep in the hip here, talking about the iliopsoas muscle, which is made up of two pieces here, the psoas major and the iliacus, both of which attach to the back of the femur, to the lesser trochanter. So that's where this goes. All right, so we'll talk about the innervations as we go too. This one gets L1 to L3. Now, this is a picture of that to illustrate it for you. You can see the greater trochanter out here, and the neck of the femur, and the head of the femur. I will pause in this presentation since I didn't do it a lot last time. After, whenever we make our way down to the knee, I'm going to pause and talk about joints a little bit more. And this one will come up in a couple of spots. The head of the femur articulating in the acetabulum. We made a big deal in the shoulder, right? When I put the head of the humerus in the shoulder joint, I spent a lot of time talking about all the things that stabilize that joint. I'm not going to do that here. Can you think of why, anatomically, your teacher would not spend a lot of time talking about the stability of this joint? It's very stable, yeah. And what anatomically teaches you that? Okay, not obturator framing, you want to say the acetabulum, the head of the femur. The acetabulum essentially covers the head of the femur. Yeah? Now, there's another reason. There are actually 3 major supporting ligaments that hold the head of this femur into that joint. And they are attached to the 3 bones of the coxsacrum. They're attached to the 3 bones of the coxsacrum. Could you make up their names? I haven't taught them to you. Each one of them has femoral in its name. And to the 3 bones of the coxsacrum. They cover the head and hold it in place. Okay, what? Okay, what are the names of the 3 bones of the hip?
Ilium, ischium, and pubis.
Ilium, ischium, and pubis. Names of the ligaments? Iliofemoral, ischiofemoral, pubofemoral. These are the 3 that hold it in place. Okay, so there's no real complication here. Now, there's an interesting little piece of anatomy on the end of this thing. There's a notch on the end of the head of the femur called the fovea capitis. And there is a round ligament. It's not a quadratus, it's a teres. Do y'all recognize those anatomical words? There's a round ligament that extends from the fovea capitis into the acetabulum. But in our hips, that ligament is not tight. It's a loose ligament. And it serves as an anatomical pathway for the blood supply into the head of the femur. The reason I mention it to you is because students wonder why this notch is there. What is that? There's a ligamentum teres, a round ligament. Teres, remember? The round ones? The ligamentum teres goes in there. And the reason I mention it here to you is because there's a very famous athlete, and I know some of the folks in this room are athletes from various perspectives. His name is Bo Jackson. And he had a hip injury that destroyed what arguably could have been the greatest career of any professional athlete in history. And it was caused by the tearing of the ligamentum teres, because there's a blood vessel that comes out of the acetabulum and goes into the head of the femur to feed it. And when he was awkwardly tackled, it pulled the head of the femur enough to rip the blood vessel in the ligamentum teres. And nobody in the medical community caught it. And so for days, he bled out. And by bleeding out, I mean the head of his femur was robbed of its blood supply, and the bone deteriorated so much that the only way for him to continue to be able to walk was for them to cut the head of the femur off and replace it with a titanium insert. He was dead. The bone died. And if they could have caught it immediately, they could have done a surgical repair of the blood vessel and saved his leg. Isn't that a tragic story? It'll help you remember. It is a tragic story. It'll help you remember the focal capitis and the attachment there. Now, when you talk about somebody who has a broken hip, it's common among women who are osteoporotic, postmenopausal ladies, and they become elderly. They stand up one day, and then they crunch, and they have to have a hip replacement. Are they doing anything to the ilium, ischium, or pubis? What is breaking?
The head of the femur.
The neck of the femur. That's where all the weight is right there, because that thing actually sticks out like this, laterally. So all of your body weight is being supported there on the neck of the femur. Notice the lesser trochanter here again is posterior. And we're going to look at this one more time in just a moment with the gluteal muscles and find an intertrochanteric line here on the posterior aspect. Y'all learned that in the lab, right? The intertrochanteric line that really goes all the way around this thing. It's a line, and sort of an imaginary line, really, that goes around separating the greater and lesser trochanters. It will be, we'll see those ligaments, and we'll also see the attachment there of the gluteal muscle. So, in just a little bit. All right. I'll show it to you when I show you those slides with the IT bands. Okay, so this is the anterior surface here. In a little bit, after we get through the quads and the hamstrings, we'll go down to the knees. And these words, medial, lateral, condyles, and epicondyles, and intercondylar fossils will mean more to you. I would like for you to learn all of the ligamentous attachments there. Break the knee open. Spend a lot of time on the shoulder. We'll spend a lot of time on the knees. Talking about the attachments there.
Off to this test.
Sorry?
That's all of this test.
Right. Yes. Okay, so now the iliacus is the next deep one. It's attached to the iliac fossa and the lesser trochanter, and it gets femoral. So two muscles making up the iliac psoas, the psoas major and the iliacus. In the dissection, where is the iliacus in relationship to the psoas major? Okay, so one more time here. Here it is. The psoas major is here. And there is your iliacus. Now, from what you just learned about innervation, what do you reckon that nerve is right there? That's the femoral. Yeah. So do you see where it's going to be? So if I want to find L2, L3, L4, and where the femoral obturator, where am I going to have to go? It's going to be deep to this muscle right here. It's going to be further back. You're not deep enough. That's the most common thing for me to say. They're going, I don't know where it is. And I say, you're not deep enough to find it yet. Okay. All right, so we'll work our way down now. You can see the iliac psoas illustrated here. Psoas major and iliacus. That's where you're going in to find the lumbar plexus. Now, this dissection that we're looking at here is also a deep dissection. And I know that because something is missing right here. Something that extends across from the anterior superior iliac spine here, across this way to the pubic bone. What have I cut in this dissection? A really important anatomical landmark. The inguinal ligament. The inguinal ligament has been cut here. And in just a moment, I'm going to find, can I draw it for you? From here, up this way, and across this way. Like this, and this, and this. Can you see that triangle? Now this one is slightly deeper. We're going to look at that one here in 1 second, the pectineus. It's on the floor of this triangle right here. So don't do it now, but later in the shower or whatever, you can palpate your leg here and find that little triangle. It's actually findable. And it's important because this is where you will find the femoral artery and the femoral nerve and the femoral vein, all in this area called the all famous femoral triangle. We'll also, in just a moment, look across here and see the tensor. Some of you know about this tensor. It comes up here to the intertrochanteric line, as I just mentioned, and it comes all the way down here to attach to the surface, the lateral surface of the tibia, which is a problem for us. This is a major aponeurosis tendon sheet here that has a very famous name. Is called the iliotibial tract, or the common, the IT band. Yeah, runners have a lot of trouble with this. It would be so much better if that thing was attached to the lateral condyle of the femur. But it goes all the way across the femur to get to the tibia. And so lots and lots of this action in the knee can rub that tendon and create a lot of pain for long distance runners. Okay, let's do the pectineus. This one's deep. The pectineus here is attached to the pectineal line of the pubis and goes across to the lesser trochanter. So are you getting your list together? I'm going to provide this for you. I have 2 or 3 sheets of this typed up. Students have developed over the years common attachments. You know a bunch of things attached to the coracoid process. You know a bunch of things attached eventually here to the anterior superior iliac spine. You know a bunch of things attached to the lesser trochanter. Today you've already seen 3 things attached to the lesser trochanter. The psoas major, the iliacus, and now the pectineus. Yes. So all of these go, they're deep muscles, right? They're attached on the back of the femur, the lesser trochanter on the posterior aspect. All right. Now let's do the adductors. These guys all get innervation from the obturator nerve. First on the list is this little thin strap-like muscle called the gracilis that goes from the inferior ramus of the pubis to the medial tibia, inferior to the medial condyle, and it gets obturator. This is the first muscle always, really, that people point out on the medial side of the leg. It's the most medial. It's the most inside your leg muscle. Little bitty strap. Now, it's not a little bitty strap in your cat, is it? It's a big old flat muscle, right? So a little bit different, has some very similar attachments. In humans, the gracilis is an adductor. Here's another adductor by name, the adductor longus. This one attaches also to the pubis and the pubertubercle. And this one, watch this, this one, so we've done the iliopsoas, and we've worked our way down to the medial side. I'm starting the medial side of the leg and working my way across on the medial aspect. This one is the first one on the list. Keep the list going. I'll keep saying it. This one is the first one on the leg that is attached to the linea aspera of the femur. The linea aspera of the femur. This is a line on the back of that bone that extends most of the distance of the shaft of that bone. Everything goes to the linea aspera. So not only are we going to see the adductors there, but we will see actually 2 of the quadricep muscles that we always think of as being on the front of our legs, attached on the linea aspera. In fact, the medialis has its proximal attachment on the back of your leg. It's a little surprising. So we'll keep that list going. I'll keep reminding you of it, the things that are attached to the linea aspera, the adductor longus. Now, have you heard something else from me already about the adductor longus? I drew for you a triangle, the femoral triangle that included the adductor longus. So I'm going to come right back to that in just a moment. This muscle here is where in relationship to the longus. This is going to be important for the triangle. Where is the adductor brevis? Why did I go from a longus to brevis? Where did I go?
Deeper.
I went deeper, yes. I went deeper. The brevis is deeper. And you can see it also attaches to the ramus of the pubic bone, attached to the pubic bone. And again, to the linea aspera. It's deep. The reason I point that out is because the adductor brevis and the pectineus also are floor muscles. They're floor muscles in the triangle. Borders being the sartorius and inguinal ligament. Okay, the last one here for the big adductors, this one is the adductor magnus. It attaches to the ischial and pubic rami and the ischial tuberosity. The ischial and pubic rami and the ischial tuberosity, is there anything about the attachment of the adductor magnus that would suggest to you it gets the name magnus? Okay, there's a lot of places where this is attached, right? So the big long list, the big muscle, all right? Also, in the order, from adductor longus to brevis to magnus, what are we doing? You just told me, deeper and deeper and deeper, right? Okay, so that's exactly what's going on here. And the tip here is, you know the ischium is your butt bone. That's what you sit on. So to say something is attached to the ischium is to say it's posterior, right? In fact, that's where we're going to put all the hamstring muscles, on the ischial tuberosity. So yes, the adductor magnus is posterior, it's attached to the ischium. And there we got it on the list, linea aspera again. Now watch this one. This one attaches, the adductor magnus attaches to the medial epicondyle of the femur. The medial epicondyle of the femur and the linea aspera. So where is it? Where is this muscle? It's not just deep, it is huge. The others are just going over to the linea aspera. This one goes all the way down to the distal end of the femur. Huge muscle, the adductor magnus. Now, twist back around to the front now, and let's do the muscles on the front of the leg and learn the triangle. So this is the sartorius. It shares an attachment with the inguinal ligament on the anterior superior iliac spine and goes to the medial tibia. It gets femoral innervation, which makes good sense. At least it makes good sense at the most proximal portions. So you ought to think about, you ought to think about sartorius. You should think about this muscle as an anterior muscle. It does in fact attach medially on the tibia. It is the longest muscle in the human body. This is the longest one we've had anywhere. So it goes all the way from the anterior superior iliac spine all the way down here to the medial tibia. Huge, long muscle. But you should think about it as anterior because it doesn't get obturator. This guy gets femoral innervation, the sartorius. All right, now here's the triangle I've been promising you all along. A couple pictures here. This femoral triangle is an anatomical region in the upper thigh that has the following boundaries: the inguinal ligament, the sartorius, and the adductor longus. All right, now your job at this point is you've learned these. Now you have to tell me where these things are attached. Okay? So the borders of the triangle are the inguinal ligament, the sartorius, and the adductor longus. Now, I know you just learned them today, but it's good to do this out loud with your teacher. What is this attachment here on the hip? The anterior superior iliac spine. Now, you guys know from the anatomy of the hip that there's another spine right here. The anterior inferior iliac spine. Now, that is going to be